Good morning all. Yesterday we were discussing about open angle closure, angle closure glaucoma, and just roughly we are just looking to the slides which we are read last time. Like, stages of angle closure, the primary angle closure suspects, primary angle closure and primary angle closure glaucoma, and we were discussing about primary angle closure glaucoma last time, and the mechanisms involved with angle closure also we discussed. The relative pupillary block and the non-pupillary block we were discussed yesterday, and now we are going to discuss lens-induced angle closure. Angle closure, lens-induced angle closure is the angle closure that is predominantly lens-induced due to a retrolenticular cause is often recognized as a secondary cause behind that. And this includes those cases in which the sudden change in lens volume or position leads to an acute or subacute intraocular pressure rise. And usually rapid progression of lens intumescence or anterior lens subluxation. All cases of pupillary block have a phacomorphic element that increases with the age as the lens thickens. And retrolenticular is malignant glaucoma, and the posterior segment causes secondary angle closure. And the combined mechanism has been proposed as formal label for the combination of angle closure and the open angle element. And next is reduced aqueous outflow. In angle closure has been postulated to be caused by the following mechanism. That is, one is appositional obstruction by the iris. Next, degeneration of the trabecular meshwork itself due to chronic or intermittent contact with the iris or damage sustained due to the elevated IOP. Next, permanent occlusion of the trabecular meshwork by peripheral anterior synechiae. The prognosis for IOP control correlates well with the extent of peripheral anterior synechiae. And risk factors like age is a risk factor, gender, females are more commonly race, Eastern and Indian Asians, then family history of glaucoma and refraction. Then eyes with pure pupillary block are usually hypermetropic. Non-pupillary block mechanism can occasionally occur in myopic eyes. And axial length. The short eyes tend to have a shallow anterior chamber secondary to a relatively anterior lens position. Eyes with nanophthalmos, axial length less than 20 meter, have a very short eye and at a particular risk. Then symptoms. The precipitating factors of angle closure include watching television in a darkened room, pharmacological mydriasis or rarely miosis. Then adoption of a semi-prone position, for example, for reading. Then acute emotional stress and some systemic medications like parasympathetic antagonist or sympathetic agonist, including inhalers for like COPD patients or asthma patients, then motion sickness patches and cold or flu medications, which all are having mydriatic effect, and topiramate and other sulfa derivatives, they cause ciliary body effusion. All these causes are precipitating factors. Then presentation can be with the intermittent symptoms of blurring, like smoke-filled room feeling and halos, that is rainbow around the lights, due to corneal epithelial edema or acutely with markedly decreased vision. Redness and ocular, periocular pain and headache can be there. Then systemic symptoms like abdominal pain and other gastrointestinal symptoms may occur in cases.
So here, the
Sir.
halos you mentioned, no?
Sir.
You usually examine the orals. They will ask you difference of halos between acute congestive glaucoma and cataract.
Okay, sir.
What are the differences? So they will ask. That is the standard question exams.
Okay, sir.
This is orals.
Okay, sir.
Yeah, you tell me afterwards. Okay.
Okay. So most of the patients with angle closure are asymptomatic, including most of those with the intermittently or chronically elevated IOP. Next is signs. Acute primary angle closure, previously called acute glaucoma. Visual acuity is usually 6/60 to hand movement. The IOP is usually very high, that is 50 to 80 mm of Hg, and conjunctival hyperemia with violaceous circumcorneal injection will be there, and corneal epithelial edema will be there. And this picture, first picture, we can see corneal epithelial edema in primary angle closure. Then tiny epithelial cyst also we can see. This this picture, the B picture showing non-reactive mid-dilated vertically, like this pupil is not that vertically oval, but it's vertically oval pupil is there, and violaceous conjunctival hyperemia with violaceous circumcorneal injection is also there in this picture. And the anterior chamber is shallow and the aqueous flare is usually present. And the pupil is non-reactive, maybe mid-dilated. And this finding is classic. And the fellow eyes typically shows an occludable angle. If this is not present, secondary causes of angle closure should be considered. Resolved acute primary angle closure in early stage, low IOP. That is due to
here again,
Sir.
one more in these exams, no, particularly orals. How do you differentiate diagnosis between acute congestive glaucoma, acute iridocyclitis, and conjunctivitis? That is one more standard question.
Sir.
Yeah. Just note down and.
Sir.
Go ahead.
Then resolved acute primary angle closure in early stage, low IOP may be due to ciliary body shutdown and effect of intensive treatment, and falls in Descemet's membrane if IOP has reduced rapidly. Here we can see Descemet membrane falls, and optic nerve head congestion and choroidal falls may be there. This is this picture post falls in Descemet membrane in post-congestive angle closure. Next, later stage, like iris atrophy with the spiral-like configuration will be there, and glaucoma that is white foci necrosis in the superficial lens, and other forms of cataract and irregular pupil due to iris sphincter or dilated damage and posterior synechia. In this picture, glaucoma fleck, and we can see the some white particles in anterior part of the lens, and this picture also we can see. Then there is posterior synechia in this picture. Here, posterior synechia we can see this. The optic nerve may be normal or exhibit varying signs of damage, including pallor and or cupping will be there. The greater the duration of attack of acute primary angle closure and the extent of post-APSC peripheral anterior synechia, the lower the likelihood of IOP control with the medical treatment alone. Then subacute angle closure is used to describe the clinical scenario of intermittent episodes of spontaneously resolving mild or moderate acute primary angle closure, and usually in patients with the pupillary block. The clinical course may be chronic or may be culminate in a more severe or unresolving episodes of acute primary angle closure. And chronic presentation, visual acuity is normal unless damage is advanced. The anterior chamber is usually shallower in a relative pupillary block than the non-pupillary block. The IOP elevation may be only intermittent. Creeping angle closure is characterized by a gradual band-like anterior advance of the apparent insertion of the iris. It starts in the deepest part of the angle superiorly and spreads circumferentially. The intermittent iridotrabecular contact may be associated with the formation of discrete peripheral anterior synechia. Individual lesions having pyramidal sawtooth appearance. In this picture, we can see primary angle closure in an international gonioscopy, narrow angle showing inferior peripheral anterior synechia. The optic nerve science depends upon the severity of the damage. Then differential diagnosis of acute IOP elevation. Then lens-induced angle closure is the first. Due to lens-induced angle closure may be due to swollen or subluxated lens. Then malignant glaucoma, that is aqueous misdirection syndrome, especially if the patient has recently undergone intraocular surgery. Other causes of secondary angle closure we have to rule out with or without pupillary block. The neovascular glaucoma may be occasionally due to sudden onset of pain and congestion. Then hypertensive uveitis. That is example iridocyclitis with the trabeculitis, particularly herpetic, including cytomegalovirus. Then glucomatocyclitis crisis, that is Posner-Schlossman syndrome. Then scleritis with or without angle closure. Then pigment dispersion, pseudoexfoliation, then orbital or retino-orbital lesions, including inflammation, retrobarbal hemorrhage, or carotid cavernous fistula. All these are differential diagnosis for acute intraocular pressure elevation. Next, we are discussing about primary congenital glaucoma. This is the classification system for the primary congenital glaucoma. Childhood glaucomas classification system. If any two or more than two of the following from this box, that is present, then congenital eye anomaly or systemic syndrome we have to look for. And the first set of points are if IOP is greater than 21 mm of Hg, then optic nerve head cupping, that is increased cup disc ratio, or asymmetry greater than or equal asymmetry between two discs, that is greater than, if it is greater than or equal to 0.2, focal thinning of NRR or half striae or increased corneal diameter, myopic shift or increased axial length. If any of these four is present, or any of these four, like two or more of present, then we have to look for congenital eye anomaly or systemic syndrome. If nothing is present, like the child is labeled as glaucoma suspect. And if systemic anomaly or syndrome is present, then we are determining that, confirming that there is a systemic involvement. Then glaucoma associated with the non-acquired systemic disease or syndrome. We are labeling like this. Then glaucoma associated with non-acquired systemic disease or syndrome, because it's congenital anomaly or systemic syndrome is present in this child. If there is no systemic involvement, then glaucoma diagnosed after congenital cataract surgery or not. Then yes, there is a history of cataract surgery. Then another ocular anomaly besides cataract we are looking for, if the present, if it is present, then glaucoma associated with the non-acquired ocular anomaly. We are labeling the child as glaucoma associated with non-acquired ocular anomaly. If another anomaly, ocular anomaly is not present, then we are labeling the child as glaucoma associated with the congenital cataract surgery. Next, congenital eye anomaly or systemic syndrome is not present in this child. Then we have to take the history of trauma, uveitis, infection, steroid use, etc. If any of this like present, then we are labeling the child in glaucoma associated with the acquired condition. If nothing is present in this child and the eye is the patient is ophthalmic, then we are labeling this as primary congenital glaucoma. Look, here any of two or more than two from the box, like IOP, optic nerve head changes, and corneal changes, or myopic shift or increased axial length, any of present, then eye is ophthalmic, then we are labeling primary congenital glaucoma according to the onset. Like we are labeling into neonatal onset, infantile, or late onset. If it is from child is detecting, we are detecting it from 0 to 1 month after birth, then it's neonatal onset. Greater than 1 month to 24 months, infantile onset, and then more than 2 years, late onset. And the patient is not ophthalmic, this box two or more than two is present, then we are labeling the child as juvenile open angle glaucoma. This is the classification of childhood glaucomas. And this box like primary pediatric glaucomas. There are primary congenital primary pediatric glaucomas and primary congenital glaucomas, secondary pediatric glaucomas, and primary pediatric glaucomas like primary congenital glaucoma, neonatal or newborn onset, infantile onset, late onset or late recognized. Next, juvenile open angle glaucoma. Then secondary pediatric glaucomas are glaucoma associated with the non-acquired ocular anomalies, glaucoma associated with the non-acquired systemic diseases, as glaucoma associated with acquired condition, then glaucoma following a cataract surgery. These are the classification based on this classification system. Next, we are discussing primary congenital glaucoma. Primary congenital glaucoma is rare with the incidence of 1 in 10,000 in many populations. Boys are more commonly affected than girls in most surveys, and involvement is more often is bilateral, often bilateral, but frequently asymmetric. It can be classified as follows: true congenital glaucoma, 40% cases are true congenital glaucoma, in which IOP is elevated during intrauterine life, and infantile glaucoma, 55% is manifests prior to age of 3, and juvenile glaucoma is the least common form. Then this IOP rises between 3 to 16 years of age. And this picture is showing primary congenital glaucoma, infant with the primary congenital glaucoma showing ophthalmos and systemic asymmetric enlargement of the cornea. We can see the right cornea is larger than the left eye. Corneal edema has resolved after successful angle surgery in this patient. Primary congenital glaucoma by definition not associated with other major ocular anomalies, thought to be caused by impaired aqueous outflow due to mild development of the anterior chamber angle, that is trabeculodystogenesis, and it's usually sporadic, but 10% are inherited in an autosomal recessive fashion with variable penetrance. Several genes have been implicated. The most important gene is CYP1B1 gene. The prognosis is dependent upon the severity and agent onset or diagnosis. Then secondary infantile glaucoma can be caused by a range of conditions, including tumors such as retinoblastoma, then persistent hyperplastic primary vitreous or uveitis. Next, diagnosis of primary congenital glaucoma. Presentation is like maybe corneal haze or large asymmetrical eyes, then watering, photophobia or blepharospasm, which is noticed by parents or health professional. In this picture, we can see corneal haze. This is asymmetrically large eyes. In this picture, we can see the photophobia and blepharospasm in a congenital glaucoma patient. Here, this table explains the corneal diameter in children, normal corneal diameter and corneal diameter which is suspicious for possible glaucoma. And in birth to 6 months of age, normal corneal diameter will be 9.5 to 11.5. And if it is more than 12 millimeter, then suspicious for a glaucoma. And 1 to 2 years is 10 to 12 millimeter normally. If it is more than 12.5, suspicious. Greater than 2 years, less than 12 is the normal. If it is greater than 30 millimeter, the child is suspicious for possible glaucoma. Corneal haze is
so usually it is like more than 12 mm corneal diameter, that is especially horizontal diameter,
sir.
below the age of 1 year.
Sir.
Below the age of 1 year.
Sir.
So more than 13 mm of corneal diameter at any age.
Sir.
It is like a indicative of ophthalmos and congenital glaucoma. So
okay.
More than 12 mm below the age of 1 year.
1 year.
And more than 13 mm at any age, at any point of time. Okay.
Okay, sir. Next is corneal haze. This is due to diffuse edema secondary to raised IOP or localized edema due to breaks in Descemet's membrane. In this picture, this eye, we can clearly see this corneal haze, and this eye also we can see. And ophthalmos, it's a large eye as a result of stretching due to elevated IOP prior to the age of 3 years. The tint sclera often appears blue due to increased vascularization of the underlying uvea. Complications can be occurred, which includes myopia and lens subluxation. This picture, severe ophthalmos, we can see this is right eye is more than left, and corneal edema is also we can see here in this picture. And harp striae are curvilinear healed breaks in Descemet's membrane. Harp striae, corneal scarring, harp striae, and vascularization we can see in this primary congenital glaucoma patients. And optic disc cupping in infants will be there, but it can be regress once IOP is normalized. Once treatment starts, it can be regress. Most normal infants exhibit no apparent cupping. In this picture, we can see harp striae and then vascularization and corneal scarring also we can see in this picture. Evaluation under general anesthesia is generally required, and intravenous ketamine lowers the IOP less than other agents. In this picture, we can see bilateral primary congenital glaucoma in a 2-month-old infant with enlarged corneas showing epithelial and stromal edema. And then
is it ketamine will really lower IOP? In which book it is written?
Sir, this is from
ketamine is an induction agent.
Sir, it increases IOP, sir. This is from Kansky, sir.
Actually, ketamine increases IOP. It is an induction agent and it increases the IOP. Before, whenever you are under evaluation under general anesthesia, before intubation and immediately after induction of anesthesia, you have to measure IOP, or else it will give false readings. Because of intubation, also you may get higher IOP.
Sir.
So actually, ketamine increases IOP.
Sir.
That's an important point. What is the normal IOP in children? What is normal IOP in pediatric?
It's around 10 to 12, sir.
10 to 12. Maybe up to 16.
Up to 16, sir.
Ketamine increases IOP than other agents. And sir.
Continue.
Sir, then congenital glaucoma clinical triad. This picture shows a 6-month-old girl with primary congenital glaucoma developed corneal edema in her left eye, and which caused photophobia, tearing, blepharospasm, and this picture shows her symptoms improved after surgical treatment. Next, slit lamp photograph depicting harp striae trace in the Descemet's layer in primary congenital glaucoma. This is severe optic nerve cupping in left eye of 8-year-old girl with juvenile open-angle glaucoma. This is reversal of cupping. This girl has end-stage juvenile open-angle glaucoma and total cupping of both optic nerves. This pictures, the above two pictures show some reverse, this picture showing cupping and the below two pictures showing reversal of cupping after treatment. Next, differential diagnosis of primary congenital glaucoma. A differential diagnosis for conditions associated with the epiphyra is like nasolacrimal duct obstruction, corneal epithelial defect or abrasion, conjunctivitis, keratitis, ocular inflammation, uveitis, trauma. There are conditions associated with the corneal enlargement or apparent enlargement. like X-linked megaloconia, exophthalmos, shallow orbits, example craniofacial dysostiosis, then axial myopia. Conditions associated with corneal clouding, like birth trauma with breaks in descent membrane, keratitis like maternal rubella herpes, corneal dystrophies like congenital hereditary and hereditary endothelial dystrophies, posterior polymorphous corneal dystrophy. Then corneal malformations including dermoid tumors, sclerocornea, choriostomas, Peters anomaly, keratomalacia. Then metabolic disorders with associated corneal abnormalities like mucopolysaccharidosis, sphingolipidosis, cystinosis. Then skin disorders affecting the cornea like congenital ichthyosis, congenital dyskeratosis. Then conditions associated with the optic nerve abnormalities, which are giving an enlarged optic nerve head picture like optic nerve pit, optic nerve coloboma, optic nerve hypoplasia or nerve malformation, optic nerve atrophy, then physiologic cupping, particularly in a large optic nerve. Then this table
Shilpa,
is...
here you mentioned about...
Sir.
Shilpa, you mentioned about breaks in Descemet's membrane.
Sir.
Here, corneal conditions associated with corneal clouding. So,
Yes.
what is the, how will you differentiate with the HAP striae and breaks in Descemet's membrane? What is this difference?
Sir, HAP striae will be breaks in Descemet.
You have to.
It's a keeled, sir.
What is the characteristics of HAP striae? When you call it as HAP striae or when you call it as birth trauma tears? That's what I mean.
Sir, HAP striae, birth trauma can be in any shape, sir. But HAP striae will be horizontal, sir.
Yeah.
Birth trauma any direction, any type, like, but HAP striae horizontal breaks.
Horizontal or oblique, yes. And mostly in here, birth trauma is induces mostly vertical or any other.
Sure.
Usually with forceps delivery.
Sure.
So we can ask in history also, like any normal delivery or assisted delivery.
Sure.
It is a vertical usually, vertical or in any manner, but especially HAPS is horizontal tears.
Sure.
Carry.
Sir Krishna, how many cases you would have seen in the HAP striae?
HAP striae usually we used to see, ma'am, in lot of juvenile cases, like whenever patient will come for later presentation also we used to see.
Okay.
HAP striae we used to see, ma'am.
Okay.
After clearing the cornea, we used to see. Yeah, because before itself we cannot appreciate because of the corneal clouding. After the trapless trap, we used to, after clearing the cornea, we used to see the HAP striae.
Okay.
And this table gives a definitions of pediatric glaucoma and glaucoma suspect. As we discussed earlier, like pediatric glaucoma is a diagnosis is based upon the IOP, optic disc, cornea, visual field, and myopia. But pediatric glaucoma suspect is no IOP related damage, at least one of the following criteria required for the diagnosis. The IOP greater than 21 mm of Hg on a 2 separate occasions, and suspicious optic disc, finally suspicious optic disc appearance for glaucoma, that is increased cup disc ratio for size of the optic disc. Then cornea, increased corneal diameter or axial length in eyes with normal IOP. Then visual field, like suspicious visual fields for glaucoma. And these findings, if it is we have to label the glaucoma suspect, the patient has no IOP related damage with at least one of the following criteria required for the diagnosis. Then the patient child we will categorize as pediatric glaucoma suspect. That's all. Thank you, sir. Completed.
Finished?
Sir, finished, sir.
You only presented primary congenital glaucoma,
Sir.
Secondary congenital glaucoma afterwards, no?
Yes, sir. Secondary. glaucoma.
Have you seen any case of ophthalmos?
Sir, almost.
Even in my early days of practice, I used to see quite a number of cases.
Sir.
But since last 10-15 years, I didn't see a single case. Maybe glaucoma specialists, referrals are going to glaucoma specialists also. That time
Maybe they are directly present into institutes, I think. Sir.
Institutes, yeah.
And especially the consanguinity of the parents is a significant risk factor and history we have to ask.
Yeah.
And usually referred by the pediatricians.
Yes.
Congenital glaucoma patients usually referred by the pediatricians because the parents will take the child to pediatricians only, thinking that any problem dealt by pediatricians.
Yeah.
Usually we used to get pediatric referrals only there in Madurai.
Yes.
And sir, please.
No, continue.
The thing is, whenever the patient is in primary congenital glaucoma, the intervention as early as possible is better. Previously, they thought we should not intervene at till particular age. But as of now, if the general anesthesia is general anesthesia is possible to give to that baby, then it is as early as possible that surgical treatment is, and only the primary modality is surgical treatment. So medications to clear the cornea or to see the findings, but especially the surgical modality of treatment that is beneficial for the child, and as early as possible to prevent its amblyopia mainly. So what is how much we delay the treatment, the glaucoma will be much more severe and the prognosis will be poor. So late onset, whatever we have mentioned, more than 1 year, it is mostly lately presented. So the presentation of baby will be late to the clinic. So those late presentations are more poorer prognosis. And especially if you come to the pathogenesis of this, the anterior chamber angle development is abnormal.
Sure.
If you see the embryology part, the neural crust migration, ciliary body, uveal tissue separating from the angle is abnormal. So that ciliary process and iris together will encroach on the trabecular meshwork, so that the obstruction of the outflow will be there. So actually that CYP1B1 gene is also associated with that only.
Sure.
So neural crest cells migration is obstructed.
That is important. Genetic counseling is very important.
Yes, sir.
And I think when it comes to medical management,
Sir.
This is the same in the lines of adult glaucoma, no?
No, sir. Mostly that carbonic anhydrase inhibitors are the primary group of drugs which we give in the congenital or any pediatric glaucomas.
Because there is no outflow channels.
Yes, sir. Yes, sir. And we have to suppress this thing, and we have these contraindications also, no, sir. Like brimonidine, we cannot give antagonists, so they may cross the blood-brain barrier, and they may cause depression. We don't know. So that will be completely contraindicated.
This beta blocker?
Beta blockers we can add on, sir. We can add on, but we have to make sure that there is no another systemic diseases which are involving, because these are all syndromic glaucomas. So if it is we are sure that there is no other systemic abnormalities, so we can give a beta blocker, or else the cardiac side effects may be there.
So Krishna, usually These
Madam.
congenital glaucoma patients, kids, they will be having some amount of corneal edema.
Yes, madam.
But the carbonic anhydrase inhibitors are known to increase corneal edema because they
Because
have
of endothelial pump defect.
mechanism.
Yes, madam.
How do we rationale using them?
Yes, madam.
such
Because
an-
especially the thing is, we cannot, we do not have any other thing, and there will be not much endothelial pump mechanisms in the early birth. And like it will be there, but not much compensatory. So, and we are also not left with any other group of drugs which can be given in those childs. But it is actually, it is not an long-term therapy. So carbonic anhydrase inhibitors giving for a long time, they will compromise the endothelial pumps and increase the corneal edema. This is only for a until we will go for a surgical treatment, we'll give only carbonic. So it is a temporary kind of medication. In anyway, that surgical modality is the final point for that congenital glaucoma.
So until we do surgery, we can give this carbonic anhydrase inhibitors.
Yes, madam.
Oh.
There is
So we
a-
can also give brinzolamide or only
We can give brinzolamide also.
okay.
And usually we cannot measure IOP in the clinical settings in these babies, ma'am. So if you have measurements like tonopen or eye care ribbon tonometry, in some older children, if we have a Perkins, we can do it in the clinics. Or else we have to be evaluated under anesthesia, so that we should be make sure there are no other ocular anomalies associated with this. Because corneal clouding with pentorch examination, the patient baby will have a photophobia and blepharoplasm. They won't allow us to see. And any other aniridias, any other corneal opacities like Peter anomalies, Agnenfeld Rager, or any other ocular anomalies associated with this, we cannot examine really in the clinics.
So corneal diameter is also very important.
The corneal diameter is definitely important. Yes, exactly. Corneal diameter and axial length we will measure in the this thing, and if permits, the optic disc cupping will cease. And gonioscopy also we use as a direct gonioscopy we use in the evaluation.
Are these anti-glaucoma drops completely contraindicated or other drops other than brinzolamide and completely contraindicated or
Brimonide is the only compound, man. Like
basically
completely contraindicated?
yes,
mechanism of this primary
Any
glaucoma
reason why it is contraindicated?
not contraindicated. It won't work because there is a trabecular mesh disease. There is no trabecular meshwork, and there are no external collector channels. This stems canals, and all these are not there. So there is what is the point of using these drugs? There is no outflow.
Sir, madam is asking about brimonidine. Why it is completely contraindicated? Like it crosses blood-brain barrier, blood-ocular barrier, and blood-brain barrier.
Okay.
So that they will cause CNS depressions, central depressions.
Oh, okay.
It may cause some respiratory these things, the centers which are depressed.
Okay.
So we should not use brimonidine compound in that babies with children, especially because they won't know, they won't tell. Even a lot of patients, adult patients also will tell that they were somnolence is there. They will happily sleep with brimonidine.
Okay.
But not much effect on vitals, respiratory or other vitals, taking like bradycardia or something. So in children, they cannot tell us what is happening to them.
Okay.
So and little amount of concentration also will cause serious side effects in this. So brimonidine is completely contraindicated.
Okay.
And other
Yeah.
things are, as sir told, latanoprost will actually act in like prostaglandins will actually act through UL outflow, but there is no trabecular meshwork. There is a mal development of trabecular meshwork, so if, they cannot act in that way.
శివకృష్ణ గారు,
Madam.
గ్లాకోమాస్ మోస్ట్లీ పిల్లర్లో వచ్చేవి క్లోజ్డ్ యాంగిల్ ఉండవా, అన్ని ఓపెన్ యాంగిల్ అయినా?
Open angle and angle anomaly. We cannot see for gonioscopy. If you do gonioscopy also, you cannot separate the structures like Schwalbe's line, trabecular meshwork, scleral spur, ciliary body. You cannot appreciate. So mal development of angle, and it is obstructing to the outflow through these structures. These structures untai kabatti we cannot call open or closed.
Okay.
అంటే ఇప్పుడు నార్మల్ పీడియాట్రిక్ గ్లాకోమాస్ లో అదర్ అసోసియేటెడ్స్ ఉన్నాయి కదా. సో ఇప్పుడు కంజెంటల్ నెక్స్ట్ ప్రైమరీ కంజెంటల్ గ్లాకోమా తర్వాత కామన్ గ్లాకోమా వచ్చేసి కంజెంటల్ గ్లాకోమా ఫాలోయింగ్ క్యాటరాక్ట్ సర్జరీ. సో కంజెంటల్ క్యాటరాక్ట్స్ రిమూవ్ చేసిన వాళ్ళకి పెరిఫెరల్ అంటీరియర్ సైనిక్ అవి ఫామ్ అయ్యి యాంగిల్ డిసీజ్ రావచ్చు.
ఓకే.
బట్ ప్రైమరీగా అయితే ఇట్స్ అన్ యాంగిల్ మాల్ డెవలప్మెంట్.
ఓకే, థ్యాంక్ యూ.
Functionally defective.
Yes, ma'am. Yes. And Shilpa, I just want
Sir, I think we should buy one toner pen, sir. Because we are getting so many kids, sir.
Yes.
At the age of from 3 months, we are getting, sir.
Yeah.
So it's better to rule out congenital glaucoma in these kids. Otherwise, we can miss some of the glaucomas.
Yeah.
I think in this conference, if it is possible, we will buy one toner pen, sir.
Somebody has to concentrate on pediatric glaucoma.
sir.
జనరల్ ప్రాక్టీషనర్ మన స్పెషాలిటీస్లో మనం చేయలేము
సార్.
గ్లకోమా వాళ్ళ ముగ్గురులో శివకృష్ణ, శ్వేత, పద్మ, వన్ ఆఫ్ దెమ్ హ్యాస్ టు టేక్ షో ఇంట్రెస్ట్ ఇన్ దిస్.
Sure, sir.
First, we should try to screen and find out the cases, sir. Then we can probably think of improving the pediatric glaucoma. First, we should start doing screening, at least with the help of a toner pen or something.
Yeah.
And especially the closest differential is CHED, sir. Congenital hereditary endothelial dystrophies.
Okay. Yeah.
So closest differential diagnosis, sir. Like whenever we think it might be a glaucoma, whenever we are going under a general anesthesia evaluation, we may find out only corneal edema is there and no other findings. So we saw, sir. We saw that closest differential diagnosis, CHED, to the congenital glaucoma. There will also be a corneal clouding.
So we are getting lot of kids with nasolacrimal duct obstruction, sir.
Yes, sir.
So as a primary thing, we have to do the ablation to rule out congenital glaucoma and refer it to the particular specialist, whether it is oculoplasty surgeon or we have to send it to glaucoma specialist. So I think we should start screening.
నేసలాక్యులర్ పరిస్థితి అవసరం లేదండి. నేసలాక్యులర్ అబ్స్ట్రక్షన్ గివ్స్ రైజ్ టు కార్నియల్ అల్సర్ అండ్ ఇన్ఫ్లమేషన్ లీడింగ్ టు గ్లకోమా. బట్ ఎనివే మీరు అన్నట్టు పర్కిన్స్ కానీ లేకపోతే ఐకేరా టోనర్ పెన్ ఇస్ ఉండాలి, మన దగ్గర ఉండాలి. అప్పుడు బ్లైండ్ చిల్డ్రన్లో చూస్తే మోస్ట్ ఆఫ్ దెమ్ ఆర్ సెకండరీ కంజెంటల్ గ్లకోమాస్ అండి. మోస్ట్లీ డ్యూ టు ట్రామా అండ్ ఇన్ఫెక్షన్ ఇన్ అవర్ కండిషన్స్ సెటప్. అండ్ ఇఫ్ యూ కేర్ఫుల్లీ ఫాలో maybe familiar traits will be Peter's anomaly, చాలా మందికి కాళ్ళ నొప్పి ఉంటాయి. మేబీ పెట్టేస్ number. We don't, we're not. Yeah, that we'll discuss afterwards.
Yes,
So, Krishna, regarding surgical management,
sir.
is it always GDD or TRAB has a given?
No, sir. First modality is like especially primary congenital. Primary congenital, it is the, as I told, it is a maldevelopment and iris tissue is coming over the trabecular mesh. So we do a trabeculotomy, the first management, sir. And usually the severity, sir. The severity of presentation, severity of corneal clouding with the enlargement of cornea and enlargement of axial, like ophthalmos, axial length increase. Based on these things, we do only trabeculotomy, or we will do trabeculotomy with trabeculectomy, trapless trap.
Okay.
So first modality is that usually the previous saying is Barken's membrane, sir. Barken's membrane over the trabecular mesh. That is nothing but a uveal tissue which is encroaching on the trabecular mesh. So that we should open, sir, completely. The 360-degree trabeculotomes will be there. So the 360 degrees we have to open that completely. Inner wall of the trabecular mesh will open. So that based on severity, we could do only trab or trab with trab. Then if it is failing, then we will go for GDD. It is not the case with other associated anomalies. If it is really axonal rigor or Peters or other things, we have to do a GDD primarily. Yes, sir.
What is the success rate of trabeculotomy?
It is there, sir. Actually, trabeculotomy success rate is there, and the patient baby cornea will be cleared, and the patient can see. And as we know, the cupping will be reversible. So patient baby will do very nicely till the 12 years or 14 years. They will do nicely. Especially the presentations at the time of presentation. What the early they are presenting and what the early we are doing surgically intervening the baby. So early intervention will give a good success rate, and later presentations will give a low success rates.
I worked with Mandal for 2 weeks in my early days.
Sir.
That time it's trabeculotomy.
Sir.
Stem canal opening, that's a beautiful surgery.
Yes, sir.
That's easy also.
That's easy.
Yeah, the others it looks very difficult. But the children can easily open stem canal.
Yes, sir.
And Hema, I mean, keratoplasties in children, what is the percentage? How many?
Sir, shall I ask Shilpa?
Yeah.
Shilpa and Sonika, you just read about.
Sir, ask something, sir.
Yeah. Carry on.
The keratoplasties in children. What are the indications?
Sir, keratoplasty
in children.
Okay, sir.
Can you elaborate on that? Yeah, that how many?
Yeah.
Okay, that is important, no?
Actually, I have done in very few patients, sir.
Yeah.
I have done lamellar keratoplasty.
Yes, that is very important, no, to prevent amblyopia and there are so many trauma or opastis.
Sir, I think Hema ma'am's network is not very good. I would like to add, sir. In kids, keratoplasty primarily we will do it for either corneal dystrophy or post-trauma or for corneal scars. These are the three main categories where we will operate. Post-trauma keratoplasty is slightly rare. It is more commonly corneal tear.
primarily, if we talk about dystrophies, then the most common dystrophy, like Dr. Shivakrishna was mentioning, is CHED, congenital hereditary endothelial dystrophy. And it's very important to differentiate this and primary glaucoma. It's impossible to differentiate that in the clinic. It's very important to take the child and examine under anesthesia the CHED and glaucomas. And the important thing here with CHED is that it doesn't require we cannot see the fundus primarily, so we cannot understand the disc damage. And CHED causes corneal thickening to the extent of almost close to 1,000 microns also. So it's a very, very thick cornea, and it only requires deciment stripping endothelial keratoplasty. It doesn't require a full thickness transplant because it's a form of endothelial dystrophy. So post transplant for kids, two important things that I can think of is in infants, if we talk about CHED, which needs DSEC, and sometimes Peters and which needs PK or sclerocornea, which will either need PK or a partial lamellar anterior lamellar keratoplasty. So for all these patients, it's becoming very important for us to manage the intraocular pressures. And EUA, examination and anesthesia, is the only way that we can assess both the graft and the pressure inside the eye and the fundus. Having an anesthetist for EUA is very important, and then having the tonopen or any of these instruments or a Perkins or these things are very important to assess the intraocular pressure. For just examining the graft, a microscope is fine. For suture removal, also the microscope is fine. As far as the pressures in children is concerned, children with graft is concerned, in more than adults, it's very important for them because the graft age, that is, supposing the child is transplanted at the age of say 6 months or 1 year, till the child is about 60 years of age, the child needs the same optic nerve to function. The grafts can be changed a number of times, but the same optic nerve head has to withstand the entire process. So it's very important to be very aggressive with managing these glaucomas. Right, Dr. Shivakrishna?
Yes, ma'am. Actually, with the post PKP or any other keratoplasties, any other intraocular surgery will have a risk for trap to fail. So, in particularly post PKP or post keratoplasties glaucomas, yes, definitely the IOP should be controlled. If possible, medically or not, will primarily take for GDT.
Sir, one more point I want to add this, because there is a glaucoma eyes, so there are high chances of expulsive hemorrhage during surgery. So I did one case in Madurai where the patient had an expulsive hemorrhage. So we have to be very cautious in planning the surgery, explaining guarded prognosis, and bring down the intraocular pressure very low, and then do the surgery. I did this case under general anesthesia, but still had this expulsive hemorrhage. So I think multi-specialist approach should be there. We should have for a transplant to do, we should have very good glaucoma specialist also to take care of the pressures. So that's what I want to add, sir.
And Sonika, Shilpa, yeah, what are the you have to read about relative pupillary block, inverse pupillary block, reverse pupillary block, or paradoxical pupillary block.
Okay. Okay.
What are all the differences, and you just let me know in the other class.
That is the fundamental question, particularly in exams like glaucoma case comes means.
Then definitely the practical or viva, you will definitely get this question. So you just read about pupillary block terminology.
Sure.
You know anything right now? You can tell.
Pupillary block, no?
relative, inverse, reverse, paradoxical.
Sir, relative
If you don't know, please
inverse.
please read it.
Okay, sir. Inverse and paradoxical, sir. These three are, sir.
How the acute glaucoma will be initiated? You go into dark room.
Sir, hello, sir.
What are the events before going for an acute attack? Sir is asking.
Sir, acute attack can be due to pupillary block, relative pupillary block or non-pupillary block.
What are all the predisposing factors?
Sir, dark room.
Why dark? Because
so miosis will occur, sir. No, myosermidriasis occurs, sir.
Then, if it is a mydriasis, then next what will happen? That's what sir is. If there is a complete mydriasis of 8 mm.
Mid-mydriasis can also causes, sir, angle closure, sir. Due to
No, I am asking about pupillary diameter. How much my mydriasis will happen? 8 mm mydriasis will happen.
Yes, sir. 7 mm, 6 mm also, sir.
In dark room, without any pharmacological events. Yeah.
In dark room, yes. 6 mm, 7 mm approximate.
It's a mid-dilated pupil. It's 4 to 5 mm. Mid-dilated pupil.
Mid-dilated, yes.
Mid-dilated pupil will only cause pupillary block, not fully dilated pupil. Why? Why, Shilpa? You are only telling the classroom.
You told the kind of acute congestive glaucoma. You told it already. Relative people with black, at what diameter it will happen, and what will happen at that diameter.
So, for a case with a shallow angles, if you dilate the patient, if it is fully dilated at a go, they won't feel anything. After going home only, they'll return back to us. As the people will come to constrict, and whether at what time the mid-dilated people will come, then only they'll have an attack. The shape of the lens.
Yes, sir. Peripherally is lesser and convex shape. So mid-dilated pupillary block.
Yes, that's why it is relative.
Yes, sir. Now understand. Yes, sir.
Then inverse, reverse, paradoxical.
We will read and then tell you.
Okay. Next class we'll discuss.
Okay, sir.
Okay. What if at all any other terminologies also, you just see about pupillary blocks.
Investigations, I think.
Sir?
Investigations, when they discuss about the UVM and OCT.
Yes, sir. Even secondary glaucomas, they can discuss. Sir. Next topic is secondary glaucomas.
Tomorrow we will continue, sir.
I don't mind. Tomorrow, who's Sonika?
Yes, sir.
Emma madam, tomorrow can we have the class? Yeah, Sir Krishna, tomorrow is okay for you?
Yes, sir. Or else next week, anything is okay.
Actually, not our problem, Papa. Shilpa and Sonika has to prepare and.
Yes, sir. Yes. Yes, sir.
Okay. We'll
you take calls, sir. Madam.
Systemic drugs which are leading to glaucoma, can we make it a topic?
Yes, ma'am. Like Ma'am, what ma'am is telling, sir, like systemic medications we have to focus on, like secondary angle closures also will come with drug-induced these things, no, sir. So
we'll discuss, madam.
And Ravikiran garu, AON క్లోజ్ యాంగిల్ అసోసియేటెడ్ అని మనం అనుకున్నాం కదా, ఒకటి 2 కేసులు చూసాం కదా, శివకృష్ణ గారితో కూడా చెప్తాం. అది కూడా ఏమైనా డిస్కషన్ పెట్టుకోవచ్చా ఒక టాపిక్ కింద?
మళ్ళీ చెప్పండి.
AON sir, anterior ischemic optic neuropathy associated with glaucoma, sir.
Differential diagnosis లో పెట్టుకుందాం మేడం.
Yes sir.
Sir, excuse me everybody, I want to also add that along with the systemic medications, can we also have this point on what are the history we should concentrate, because that is very important when we deal the case. First, when the patient comes, we won't see, okay, this is primary, this is secondary. We'll just see it as a case. Then what is the history points that are important that we have to ask, or we have to know, or to differentiate between that and this? I think we should also discuss on that points as well. If possible, if we are discussing all this, can we also add about the history regarding especially systemic conditions?
Yeah, that's very important. Actually, glaucoma patient will not come with a complaint.
They won't give any complaints unless we ask them, or we keep asking them questions. Leading questions only will get proper answers, sir. But we should know what proper leading questions we should ask them.
Yeah, I think already when PCSG,
if possible.
Yeah, we'll have tell them to. We'll do one thing, Sweta. Ask them to present a case of glaucoma. Case presentation. That time I think we'll ask all these things.
Yes, madam.
After this theory part is over,
there will be an active discussion also when they present the case.
Yeah, they can virtually present the case. We'll discuss. We'll present the case with all the from history to fundus, the visual fields. Okay, madam.
హలో,
చెప్పండి మేడం.
అంతే సార్, అదే సార్, అదే
డిస్కస్ చేద్దామండి కొన్ని ఇంపార్టెంట్ పాయింట్స్, అంటే అప్రోప్రియట్ టైంలో దాని గురించి. మీదేమో అట్లా సెకండరీ రకమ్స్తో వచ్చేస్తుంది మేడం, మీరు చెప్పిన పాయింట్. సిస్టమిక్ డిసీజ్ అసోసియేట్ విత్ సిస్టమిక్ డిసీజ్ అండ్ డ్రగ్స్ సెకండరీ రకమ్స్ వచ్చేస్తుంది. శ్వేత చెప్పింది ఒక కేసు ప్రెజెంటేషన్లో పెట్టి, ఆ కేసు ప్రెజెంటేషన్లో విల్ హ్యావ్ ఏ గుడ్ డిస్కషన్.
Okay, sir.
I think it's already 8:05.
Yes, sir.
It's a good presentation. I think there's still more to go.
Sir, one more point I just want to add in plateau iris configuration.
Yeah.
Whenever we are going for a laser topic, we can discuss actually. I just want to keep a note that plateau iris configuration is better treated by laser iridoplasty than laser iridotomy.
Yeah.
Peripheral iridotomy. It is a plasty which is helpful.
Yeah.
But nowadays that organ laser iridoplasty is less commonly doing.
Organ, though, they cannot do with YAG.
We cannot do with YAG, sir. But YAG also we can do with not a normal this thing, sir. We have to come down to 539. But then also it will be penetrating, sir. YAG is like that. It is a penetrating laser. Organ will have a pigment absorption.
Like SLT.
Like SLT. So it will have a plastic. Yes, sir. Okay, sir. With this, we can end the meeting, sir. Thank you. Thanks.
Thanks, Shilpa.
Thank you, sir.
You both read and tell. You both read and tell me.
Sir.
Okay.
Yes, sir.
Bye.